Okay, everyone, you guys want to get started? I mean, we could talk about music all day as well, but if we wrap this early, maybe we can move into that next. So my name is Laurie Van Hoos. I'm a policy director here at the Texas Association of Health Plans, and I'm very excited that you all are joining us today on our panel about innovative delivery models for individuals with intellectual and developmental disabilities. Interestingly enough, we put this panel together last week and then added another person today. Okay, so as I was saying, a couple weeks ago we were looking at our agenda and noted that we didn't have a panel on one of the most interesting topics that's going on in Texas right now, which is how we're going to innovate delivery models for individuals with developmental disabilities, intellectual and developmental disabilities, So we decided to put one together, and I'm very excited to announce our speakers. So first, speaking first is Leah Rummel. I think most of you know Leah. She's with United Healthcare. I mean, she has spearheaded and helped lead the charge around improving care and supports for individuals with IDD in Texas. So she's going to give us an overview of some of the the carve-in pilot that's about to take place. And then after her, we have Dr. Trivedi. He's the Chief Strategy Officer for Station MD. He's a board-certified emergency medicine physician and the founding partner of Station MD, and I'm really excited to hear more about the model and the work that they're doing with individuals with developmental disabilities. And then after Dr. Trivedi, we have Brooke Hofield. She works with Texas Advocates and works on peer support projects in both Austin and San Antonio. We're going to hear a little bit about how peer supports are an important benefit for individuals with intellectual and developmental disabilities. And then Justin Frazier is going to go last, and he's with Mazars. And we were talking earlier, and he's seen some of the innovative models that have taken place in some of the other states. So we're going to get to hear a little bit about what other states are doing. Texas is always the best, but it'll be good to learn from some others. But he has over 15 years of experience helping diverse healthcare entities to assist the underserved and has helped both large and small Medicare, Medicaid, MLTC, and QHP health plans with regulatory affairs, operations, and business development. So without further ado, I'm going to go ahead and pass it over to Leah, who's going to kind of give us an update and level set us so we know what's going on in Texas and what's coming here in the near future.
All right. Okay. Well, thank you, everybody, for being here today to hear this stimulating conversation. Actually, it's kind of exciting if you're a nerd in Medicaid. This is like a...
Medicaid Nerds Unite.
These are Medicaid Nerds Unite, and this is an exciting topic for us. So in 2013, there was a bill that was passed that basically started the process of moving our last remaining fee-for-service population in Texas into Medicaid managed care. And it's for persons with intellectual disabilities. And the commission moved forward, the Health and Human Services Commission moved forward with that transition. They set up a RFP. There was supposed to be a pilot. United Healthcare, along with another health plan, were selected, and then it all went downhill. And I wasn't surprised because really when you're talking about moving populations that are currently in waivers into a completely new process and you don't spend a lot of time really planning it's probably not going to have good outcomes. So we went back to the drawing board and said, what is the end goal here for persons with intellectual disabilities? How do we really want to build a good program? And so we retook that legislation, we amended it, and we added some language that basically says, let's start a new waiver for persons with intellectual disabilities. Let's take our current STAR Plus waiver, because in Texas, believe it or not, we have 150,000 people on interest list, and a lot of those people are already in STAR Plus. Let's not interrupt people who are already getting services, and let's test the model and see how it works, and then we'll start moving people who are already in these waivers, but very slowly on a slow basis into the new model that hopefully by that time we have tested and it won't have too much of disruption into the current population. So that is what was passed, and that is the STAR Plus pilot is what they're calling it. So in the process of doing that, what was also added to that legislation was, I'll go into that in a minute. Go to the next slide. Okay, good. So I'm giving you a 10-minute overview of a very complex topic, but feel free to ask me questions. And I'm trying to make this as easy as possible, so I did graphics, okay? So if you look at what we have currently, the first on the top is the pilot goes from 9/1/2023 to 9/1/2025. That's the pilot period, and you happen to notice that is the same time as the new Star Plus RFP is supposed to also happen 9/1/23. And so this is going to be part of the RFP bid. It's only for our current Star Plus members, so there's no disruption to the current population. It is for members that have an IDD diagnosis, and diagnosis that they use is what we call, it's fairly broad, that they use for a class definition. So there's a waiver in Texas called class, and there are, I don't know, hundreds of diagnoses for that, to be eligible for that particular waiver. And so they used that same definition and moved it into who's going to be eligible here. And then the legislation also allowed people who are not diagnosed before age 21, people with brain injuries, people who have other functional needs, people with autism that were diagnosed after age 21 to be added to that. It is going to be done as a pilot in one service area, so they have chosen Bear, that's not Bexar, that's Bear, which is San Antonio. They chose that to be the preferred site for the pilot, but they've also have backup for Northeast, and then the third one would be Tarrant. Only 2 plans will be selected to do this pilot, so it'll be competitively bid. And if you look on the next slide, then once that happens, at 9/1/2026, if it's successful, then they would move for that to be statewide. And so what does that mean for Texas? And my friends who have IDD, including Brick, don't like to kind of hear this, but it actually means that we're going to really have a big impact on people who have been waiting for a long time to get services. For, you know, the wait list in Texas is around 15 years, which is kind of shocking. So at least they'll be able to have, you know, these services get into place. In the Star Plus waiver, you don't wait for services if you're SSI eligible and below. You're on an interest list if you're above that income level, and so it means it will really serve a lot of people early that have been waiting for a long time for services, so, which is very exciting for me. There are some key successes in the pilot, which, you know, I think is sort of moving to the next phase. And one of those is helping people with intellectual disabilities and those with functional needs live in housing in the least restrictive environment, find employment that's meaningful, having a person-centered plan. And so there's a really great new person-centered plan model that the state has developed. I think it's really good. And then also having more of an integrated service coordination model. It's sort of a team approach for service coordination, so that's an important thing. And then once that happens, at 9/1/2027, they start the first waiver to transition over, and it's actually the easiest waiver because that waiver only has about $16,000 in benefits. And so that waiver will move into the first round, and for you guys to know that the benefits that are in this particular waiver all mimic all of these additional class, Texas Home Living, ACS benefits. So there should be all the benefits available to them. Then class will come in 2029. HCS and deaf, blind, and multiple disabilities, except for the housing, the residential portion will come in 2031, and then in 2031 they'll do a feasibility on moving the housing portion over. So that was my easy way of, I thought it would be easier to look at a diagram than trying to have a lot of words. The next one is just talking about who's coming in. And so this is kind of what I talked about, those people with intellectual disabilities that meet the class definition, and as I told you, there's hundreds of diagnoses that are aligned with that. Persons with autism, those with acquired and brain injury or traumatic brain injury, and then those basically that have a functional need that is aligned with the needs of persons that are, you know, have IDD and autism and other things. So this will help you kind of figure out what the population is, and I'm going to tell you sort of the numbers on that in a minute. The next thing is the benefits. So what we try to do, and I serve on the IDD Intellectual and Intelligent Redesign Advisory Committee along with Karen. And so the subcommittee that I work on really helped to define what the benefits are. So we took the pilot benefits that are really currently in the Star Plus waiver, because the law says everything in the Star Plus waiver has to be available. And then we also added some additional benefits that were defined in the legislation. And then we, as an advisory committee, recommended some additional benefits that we really felt like, especially with behavioral health, we feel like this population needs much more support in behavioral health, and we've built up a really strong behavioral health component, some other things. So these are the benefits that we are recommending be part of the waiver portion of the benefit, along with, of course, acute services. I will point out a couple of things. The enhanced enhanced behavioral supports is sort of like ABA on steroids, but it's a lot more support for this population, trying to keep them in the community. And then the other real big one that we really worked on is this behavioral health crisis intervention benefit that is more like the START program, if you guys are familiar with that, where you really, when people are in crisis, they have a place for them to be able to land without going into a hospital, stabilize, and get back out in the community. So there's a program like that here in Texas. The next one is really talking about where or why did they choose the service areas they did. And so if you look at, I put a green arrow above Bear. It's kind of hard to see, but they ran the numbers on our current population and how many people are we talking about in the service delivery area. And in Bear, there's 16,000 individuals, and this is an opt-out program. So what will happen is in 9/1/2023, they will move 16,208 people into the pilot. And if a person does not want to be in the program, they can opt out. I don't know why anybody wouldn't want to be in this program because it's actually pretty phenomenal.
And Leah, if they opt out, they don't get those additional services, correct?
Correct. They would not be eligible for this additional services. So let's see, there was something else. Hidalgo is on here. That was not an option because it just was not going to work for this particular population. So this is getting a little bit nerdy here for those of you who kind of want to know how is the eligibility done, how is it going to be assessed, how are people going to actually get into the process. So if you look at it, a person with IDD is identified by the state. They do an automatic opt-in, and if the person doesn't want to be in the pilot, they can opt themselves out. There is an assessment that will be done by a new assessment tool. For those of you health plans in here, I put these in here purposely so you're not in shock and awe of the fact that there's new assessments and new things to do. But there's this new assessment called the Inter-REI. It's not been decided exactly who is going to be doing that, but it is a very intensive assessment. I really like it. I think it really covers the things that you really need to have. And then on top of that, there will be a My Life plan, a person-centered plan development, which has been designed by HHSC with lots of input from people. It's really great person-centered planning. And then there will be possibly a CFC assessment. We're hearing they may consider dropping that. And then there will be quarterly meetings with the members. There'll be updates to the Inter-REI and the reports, and so it'll continue to have reporting on those things that they really have in their person-centered plan and in their plan of care on how are we progressing, and that will be reported back to the health plan and then reported back to the agency to see how we're doing. All right, I kind of already went over this. This is what the successes are in the pilot, but you'll have it in case you want to see it again. I wanted to talk about the things, because this is a panel on innovations, some things that are really different in this model. There's a new integrated service coordination plan. And so you'll have a new model where you're going to be partnering with the LIDAs in Texas and with the comprehensive service providers, which is a new provider for the managed care organizations to deal with, to do sort of a, I'm going to call it a group service coordination model. And so that's going to be new for us, and it's going to require a lot of interaction between other people while you're doing your assessments of persons that are in the STAR Plus pilot. There are new LTSS benefits, including, I put DayHab in here because it's easier for everybody to understand, but it's a really integrated, socialized, specialized services that are in the community kind of, but it's basically DayHab that is in the community. The housing navigator is new. We haven't had that in Texas, and for this population, it's more than just, sitting down with a person saying where you want to live. This person actually really works with the person that's on the program, trying to figure out what's the best options for them, and then doesn't leave them at that point, make sure that they can continue to maintain that. So that'll be a benefit that's going to be added. I already talked to you about the enhanced behavioral support, the crisis intervention. There's transportation, which we hadn't had previously in some of our managed care models. There's a remote monitoring that we specifically got into the benefit that allows for some remote monitoring, of course, with privacy standards aligned with that, but hopefully would be able to allow a person to live more independently in the community without having someone kind of standing over them all the time. My son, who has special needs, and he does not like having somebody hanging over him 24 hours a day, so we have that at my house, and I love it. The new adult foster care benefit, we have an adult foster care benefit in Star Plus. Nobody ever uses it because it's just not designed properly, and so we were able to really look at that model and try to undo the benefit and make it more usable for persons in the pilot. And so that will be a big part of, where to live in the community. And then there is a new assisted living benefit for 4 and less for this population. Already told you about the NRRA and the My Life Plan. There's a new LTSS comprehensive service provider that's included in the model that would have many services under their contract. And there is APMs that are aligned with that you can use if you want to do the contracting with it. It's very new for us and them. There is some employment goals and housing goals. And then for the first time ever, we're going to have IDD duals in this population. So those are all things that we're going to have to really work on and innovate. And I think you're going to see all kinds of exciting things come from this pilot. I'm pretty excited about it. I put the timeline in there, but I kind of already went over that with you. And that's me going over this in hopefully not too much more than 10 minutes. So, yeah.
That was great. Do you have any questions just right now for Leah, since it is kind of a complicated subject, before we move on to other speakers?
Any questions on that?
You got it all, clear as mud, right?
Okay, good.
It's a lot, it's very exciting. And I am excited to hear a little bit after Dr. Trivedi speaks, Justin, what you think after seeing this in some of the other states. So I'm going to turn over to Dr. Trivedi. You can drive from down here, or I can drive the slides for you, whatever you prefer.
No, that's fine. I can go down there.
So Station MD came and met with the Texas Association of Health Plans a couple weeks ago, and we were so impressed with this model and what they're doing. That's what kind of triggered the conversation that we don't have anything on IDD on our agenda, so let's change that. So I'm excited to have you.
Thanks. I hit just this one right here?
Yep.
Okay. Great. Well, thank you very much for having us. And it is a bit strange not seeing everyone in like a Brady Bunch grid and actually in person, but it's refreshing. And thank you for letting me be part of this great panel and doing this at the last minute. So I'm going to just take a few minutes to talk about our organization, what we do, and really I've been had good fortune of meeting with Leah and knowing her and discussing our services and solution for quite some time now, and she is a great advocate. Really, that right there says what we do in our mission. Our mission is really to elevate the quality of medical care for individuals with IDD. We do that using telehealth to deliver that care. I myself am a physician and one of the founders of the organization, and we've been doing this for about 6-7 years. And I think what the main thing that is important to emphasize here is our physicians are, of course, board certified and all licensed in Texas and carefully vetted by us, but they all go through a specialized curriculum and training to understand this population. The clinical aspects of this population, the non-clinical aspects of this population, the nuances. I can say this as a physician. Before I started this organization, I didn't really understand the details of this population, how they live, some of the comorbidities that I really need to address. And I think that's critical. That's very important. This population deserves to have clinicians that understand their needs and understand how they live and understand that is a unique population that really deserves proper care. We provide this care to about 30,000, 35,000 individuals in about 13 states, doing about 20 or so thousand virtual encounters annually, just with individuals with IDD. We consider ourselves advocates. I think the disability community in general has a very strong voice, and we consider ourselves advocates in this space. And I think that the more people understand there's the needs of this population, I think the better. So, what are the frequent uses of ER use or urgent care use for this subset? This population tends to have comorbidities that make them more vulnerable. They have pulmonary issues, behavioral issues, GI issues that you or I may have a fever, but it's a lot different than someone who's nonverbal or maybe has a PEG tube or other issues. So they do have certain medical conditions. But a lot of it is because they don't have access. They don't have access to the medical care that I think that they deserve and then that they really require. They may have a primary care physician or a clinic, but that physician may not be available. They may be busy with other patients, or they may not have the same technology we do to visualize the individual to really provide the care that they need. And then, of course, there are a lot of regulatory requirements, well-intentioned rules and laws that are put in place, but unfortunately have unintended consequences, which force the individual to go to get care when they don't necessarily need it. Really, with our goal is to really provide personalized care in a non-disruptive setting, and what better than in the individual's own home setting, understanding there are limitations. So, I work in the ER and I get paid to be in the ER, and I don't like being in the ER many times. So imagine going there and you're nonverbal or you have sensory issues. It's quite frightening. I call it the trauma of transport. Just getting someone there to the emergency department or urgent care, it is not easy. Of course, we have to talk about COVID in this day and age, and you're putting the individual at risk. You're putting the person that's bringing them at risk. And it's extremely disruptive. I've talked to family members that, it takes days to weeks to stabilize someone after being in an ER, urgent care, or office setting. And I put in their missed medications. I've been practicing for about 20 years, and I've had many individuals come simply for a med refill because they can't find a physician. It's Friday afternoon, and they don't have enough Dilantin, and they can't reach anyone, and maybe the physician isn't comfortable writing it. So it's a real issue, and I think anyone that has a touch point to this population will tell you it's not a great experience. So, I've already mentioned the trauma to the individual and the exposure, but it's also unspecialized care. My colleagues in the ER are great. They're wonderful, but they have no special training to understand the needs of this population, both clinical and non-clinical. They don't know what a DSP is or how this population lives, and they end up getting suboptimal care because of that. As a result of that, they tend to get over-tested, over-hospitalized. So you have that combination of suboptimal care and excessive costs. And really, this was me before I started Station MD with my partners and all of our physicians. It's something that we've experienced and really was the nidus for us starting this organization. I do want to mention this. Again, we have to mention COVID, any discussion about healthcare. And this was just an alarming study that came out earlier this year, I believe, that said having an intellectual disability is the highest independent risk factor for contracting COVID and dying from COVID outside of age. Really devastating if you take a step back and think about that. Not obesity, not smoking, and intellectual disability. So again, I was surprised it didn't get much more traction, but I'm very confident that a solution like ours, keeping people at home, has saved lives, literally. Not just individuals, but also support staff. So, telehealth, it's in the news. I think if there's any silver lining to the pandemic, it's that telehealth has proven itself as a viable means and a modality of delivering care. I would argue that the value of telehealth is even greater for individuals with IDD and certain vulnerable populations. If you struggle with finding a specialized physician, you have to drive hours to get to that physician who understands you. If you require someone else to take you to your appointments, or you need a specialized transportation, it is a game changer. It is a disruptive technology in the sense that it is a better way of doing things. It is not a substitute. It's superior care, in my opinion. Understanding there are limitations, and it's more convenient. I think I'm looking around the room. I think all of us kind of remember going to a video store and getting a video to see a movie. I don't know. Does anyone do that anymore? No one does. Because there's a better way of doing things, a more convenient, a more effective way. And I really look at telemedicine, if done properly, really as one of those disruptive technologies that will change the way we deliver care. So on the left is a problem, the right solution. Lack of access. With telehealth, there are no geographic impediments. We can be in any part of the state of Texas as long as there's a Wi-Fi signal or a broadband. I know that's not always the case, but it does allow you to expand. All of our physicians go through that specialized training, which I mentioned, and we also have access to medical records. For those of you who have worked in this with this population, what typically happens is if they're in a group home setting, if they're fortunate enough to be at home with the family member who knows them when they go to the doctor's office or ER, it's great. Most family members know way more about the individual and the medical aspects of their care than certain physicians. But if not, they come with a direct support professional with a big binder that looks like a phone book. No one reads that, and you're kind of flying blind. And I think having access to medical records, which we've developed and in our portal, is really important. And then we're available 24 hours a day, 7 days a week to provide this care. We provide full documentation of our encounter and help coordinate care with the primary care physician. This is just a screenshot of that portal where it's what happened, what transpired, what was the chief complaint, what was the outcome. Not all cases need to be emergent. We do med refills, med reconciliation, behavior changes. In this population, constipation, if not addressed, turns into bowel obstruction. UTI turns into urosepsis. And these kind of issues are frequently not addressed, and this leads to that cascade of ER hospitalization, and then of course, excessive costs. Lastly, I'll just go through some quick outcomes. This has been very consistent throughout this year. Close to 90% of the calls we get, we are able to keep the individual in their home setting, meaning we don't have to send them out. And then these are just some of the reasons that we send. I don't know if you can see really that well, but the blue are the ones where we keep in place. The gray are the ones we send out. And if we do send someone out to the urgent care facility or ER, we will call in advance and say, hey, John is coming for his leg swelling. He just needs an ultrasound for a DVT. Please don't do a CAT scan. He doesn't need blood work. And if you have him in the ER waiting room for too long, he's going to decompensate. So it oftentimes helps expedite the care and hopefully in the throughput, but eliminates a lot of unnecessary testing and makes the experience a little better if at all possible. Lastly, I think what's relevant for this audience is this was data from an MCO that we partnered with in New York. This was 1,100 individuals. After 10 months, we had about 537 calls. And their data showed they estimated the savings to be roughly $1,300 to $1,900 per member on medical costs, 1.5 to 2.1 million in terms of ER and hospitalization costs. So I think that, again, it is a solution that most importantly will improve outcomes. It's a solution that families want, individuals want, but also does have an ROI. There are some savings to be had, and it's a differentiator. I think that it is a solution that will really be the standard of care, but it can't just be ordinary telemedicine. This population deserves a telehealth solution with clinicians that are trained, that understand them, not only the clinical aspects, as I said, but the non-clinical. And we're excited. We are starting to do some work in Texas, and we're hoping to expand, and we're really excited about the upcoming pilot. And thank you.
Thank you very much. Appreciate that. And I wanted to pass it off to Brooke. Would you like to talk to us a little bit about something that we've been talking about in the State Medicaid Managed Care Advisory Committee? I see a couple of my colleagues there, and I see in the IDD Advisory Committee. We've been talking about, we added peer supports in the Texas Medicaid program many years ago, but we did it for behavioral health. And we did not do it for the IDD population. And so we asked Brooke to come join us today to talk a little bit about what peer supports means for the IDD population and why it's so important. So Brooke, if I'll hand it over to you, give you a couple minutes to kind of give us an overview of peer supports and why it's so important.
Yeah, so I'm Brooke, and I'm not fancy and don't have a slideshow. So in 2018, I'm the co-executive director for Texas Advocates. In 2018, we received a grant from the Texas Council for Developmental Disabilities. It's they're a federally funded organization that provides grants to nonprofits, a lot to self-advocacy groups. So we got a grant to go into the Austin and San Antonio state-supported living centers. The original grant was we could go to any institutional setting. So we chose Austin and San Antonio state-supported living centers. Unfortunately, because of COVID, we had to leave Austin. Their program wasn't compatible with ours with the restrictions. So we're currently in Austin at the Mary Lee Foundation, and then we're in San Antonio at the State Supported Living Center. So we have 5 peer support specialists in Austin. Five peer support specialists in San Antonio and 4 peer support specialists in Austin currently. And we meet monthly with the residents, and we talk about goal setting and dreams and just different things that they want to talk about. Our meetings are very peer-led, so the residents kind of help us pick maybe what they want to talk about. And so we've talked about goals, dreams, self-determination, self-advocacy. We talked about communication skills. And then outside of our regular monthly meetings, in Austin especially, the peer support specialists are now getting together with the residents to hang out, maybe watch a football game, just to really create friendships. And then they're able to, after those friendships are built, then they're able to talk about more of the feelings and things that they're going through. One of the first stories that comes to mind was someone from San Antonio, and the peer support specialist and one of the residents happened to have diabetes, and there was a diabetes conference coming up, and so they were able to go to that together, and the peer support specialist was able to support the resident to attend something that he probably otherwise would not have had the resources or been confident enough to go and engage. And so our hope is that this is just the takeoff point, that this project was just kind of the takeoff point to then go and launch peer support into the next several years. We were really hopeful during the last legislative session that we would be able to put peer support in IDD in the waiver. Unfortunately, the timing was off, and we just decided that it would be better to take the interim and really figure out what it could look like before we just jumped off into something. So that's kind of our project in a nutshell, is just meeting with the residents as a whole, and that's where we do different activities, and then them really getting together with their peer support specialist, the peer support specialists and the residents getting together. I will tell you, in Austin, some of them get together every day. I have to tell them, stop, you're going to go over your hours. So they love getting together and hanging out, and they are paid, which is amazing. It is a 30-hour a month paid position. So they do it as a job, but none of them do it for the money. And we get to do a lot of really cool stuff. As things are opening back up, the residents, especially in Austin, are starting to ask for more activities to happen in the community. So we might go to Starbucks or might have dinner somewhere, or just to kind of create social opportunities within peer support. Because what we find is people with disabilities get a lot of services, but they don't get a lot of opportunities to socialize. And so it's almost like peer support is helping us merge those two together.
Thank you, Brooke. That is awesome. And we look forward to working with you to maybe convince the legislature to add it as a covered Medicaid benefit.
Hopefully we'll get them in the next session, for sure.
Okay, and next we're going to have Justin. So, Justin, you've heard kind of what's going on in Texas. And I'd really like to hear your take on what you think about what we're doing here and what's going on kind of outside of Texas and what can we learn or where should we look to learn more?
Oh, absolutely. Thank you all for having me. I think some of you might know my story. I was just minding my own business, working in a booth, and then I was asked to be on a panel. I asked, what's the topic? They said IDD. Thank God for Google. Looked it up. And so I've made myself a subject matter expert. So thank you for having me. But in all seriousness, one of the most rewarding parts of my career is I work with an organization that is responsible for building two of the IDD plans in New York State, which is just extremely rewarding to be a part of that because just philosophically, a managed care plan that's responsible for our health and responsible for making us healthy and curing is really not a core competency to offer long-term support services. So we have an enigma here because we're taking an insurance plan and we're saying you have a network of doctors, and unlike Station MD, doctors who are excellent at what they do but are not trained in this population. And then you're carving in the IDD population, which oftentimes after the diagnosis, it's less about the doctor and it's more about the long-term support services and what experience do insurance plans even have with long-term support services. So this is the challenge, and I can explain what New York did to attempt to solve for it because it's still a work in progress. There's two programs in New York. There's the FIDA program, and there's one plan FIDA stands for Fully Integrated Dual Program. So this is a optional program for the IDD population to choose to join. The other program is the SIPPL, which is a mandatory dual program. It's part of the 1115 waiver. This program, is it happening? Is it not happening? Are they building? Where are we? When's the rollout? You know, it's as much political as it is, it's politically stalled as much as it is to a reality. So between these two programs, it's really trying to come up with a system that would be the best. I mean, the trend that my colleagues and I are seeing is that more states are carving this in. By carve in, what I mean is in the world of Medicaid managed care, I explained earlier, I was talking to Malik, in the world of Medicaid managed care, there's populations that are carved out of mandatory Medicaid managed care, and then there's populations that are carved in. In some ways, I have a friend who works in policy for a consulting firm. And the IDD population he calls the last frontier. This is the population that is the last to be carved into managed care. Most states are just trying to find a way to deal with this population, to best serve this population. And it's still unknown, is managed care the best way to deal with this population? And that's the verdict still to be seen. I read a report from FedCap, which is the parent company from Easter Seals, that the most successful of these programs are the ones that are only paid by achieving health goals, including job placement, including shelter, including group housing. And so it is not like traditional Medicaid where they are paid a capitation just by having a member enrolled, but they're only paid by achieving these quality metrics. And that is probably the best solution. We'll see what other states. I believe when I last did my research, I think there's 11 states. I learned about Texas only today. So this would make you number 12, I believe. So it still really is a new frontier. But it is it's extremely important. It is a population that needs to be cared for, and we just hope that managed care can step up and really provide the support and long-term support services that the population needs to strive and achieve.
Justin, have you seen see the other states do it the way we're doing it with like a pilot, or are they all going all in?
Well, one can argue, is the 1115 waiver a pilot, or is it all in? I mean, it's a really interesting point, because you have the 1115 waiver, then the administration changes, and then it's very murky as in whether it's a pilot. New York says it's all in, but the reality is the SIPPL, it's incorporated, but only the FIDA program has members right now. So,
do we have any questions from the audience? Dr. Trivedi, I wanted to ask you, how did you guys develop your model? I mean, what triggered? I mean, it's obviously something that was really needed, but what triggered it? Is there the story behind the story, or what really moved you guys in this direction?
It was all my idea.
Okay, great.
No, it was honestly, it was born out of our experience in the ER. I mean, having been there and seeing individuals come for reasons that they don't need to be in the ER. I mean, that happens all the time. Mm-hmm. But now add that layer of someone is unable to express themselves, or someone is with a support staff or family member that is, it's an ER, it's a chaotic environment, and you watch someone decompensate. And then add that, I should know more about this individual than I was ever taught in medical school. And that was really the kind of, the idea was generated that way, that is there a better way? And we started exploring telehealth 6-7 years ago, and obviously the pandemic kind of really accelerated that. But it was really just born out of really just saying that there's got to be a better way than the way we're currently providing care for this population. So
there has to be a better way. Leah, one question for you. You've been working on this for so long, and this is, I think everyone that has heard Leah talk about this knows the passion behind it, and this is big to her. What does success look like?
Well, I'm hoping that we do a paradigm shift in Texas and really value people with intellectual disabilities for who they are, and that they can live as independently as any of the rest of us, as long as they have the right supports. I think about persons with intellectual disabilities that end up in institutions, and many of those people don't need to be in institutions, and you wonder, do we value these people? And so, I look at my son, and I think I would like the same thing for all persons with intellectual disabilities, to be able to be the fifth Beatle. That's his goal. And for him to I never in my wildest dreams thought that he would MC a radio show on the Beatles every quarter, and be sitting on a radio show and then be featured on a film about it, and then be nominated for a Grammy for it. Not a Grammy, but an Emmy for it. And so. And I, never in my wildest dream thought he would hold 3 jobs, but he's just like any other, young man making his way through the world, and I wish that for, that's what you want as a goal, and I'm hoping that this program allows more of that flexibility, more living independently, more, jobs, really looking at jobs. I mean, I talk to people and they're like, oh yeah, there's a really great job at McDonald's down the street. Well, my son doesn't want to work at McDonald's. He wants to work at what he loves, and so it's the same thing. You just want the same thing for these individuals that you want for all other young adults as they make their way through the life. So. And
you missed one of the most important life goals that he got. He got to meet a Beatle.
Oh, that's right. He got
personally
to meet
invited to meet a Beatle.
Mr. Paul McCartney.
Wow.
Sent him a limo, right, to pick him up and take him to the show?
Yes. Yeah. The limo was the best part for me because I couldn't figure out how we're going to get down there. So.
And then I think to wrap it up, Brooke, I want to give you the last word. In addition to peer supports, what do you think is one of the most important benefits for individuals with intellectual developmental disabilities? Housing, employment, what's the most important benefit other than peer supports do you think we really need to be focusing on as we move this population into managed care?
I think transportation. If you can't get to work or to school or church or wherever, you're not going to be able to fully integrate into society. And so I think that transportation is something that Texas historically has not put a lot of thought into. There's just so many rural rural counties, and things are so spread out. And then, so I would say transportation, just being able to just, call up a ride and go where you want to go without having to plan it out so many days in advance.
And then I was going to ask you, did the transportation companies plant that with you? Because they have a panel coming up next. So.
No, they didn't, but I did see that. Yes, I'm an avid Uber and Lyft rider, so they definitely have a lot of my money.
We have one question. Cindy?
I have a question. You talked about peer support specialists, and I think you said that they had 30 hours of training. Can you talk just briefly about what the training entails? And then what are the qualities that make for a successful peer support specialist?
Okay, so they have 30 hours a month to work as a peer support specialist. But as far as training goes, we provide an onboarding training when we hire them as peer support specialists. And then we try a couple times a year to bring them together here in Austin. And do like a one-day training where we just kind of go over whatever we need to go over, if there's been any like problems or anything that we need to discuss. And then as far as qualities, we need them to be able to self-manage. So Texas Advocates only has 2 staff. We have 2 people, well, we have 3 staff, 2 people work on this project. So they need to be able to self-manage. Because I'm not there every day to tell them what to do. They need to be able to engage the peer support specialist. I would say they need to be patient and just really have the best interest of the person in mind. And maybe what they want to do is not what the resident wants to do. And then I think they need to be creative in figuring out things to do with the peer support specialist. On just like a quick story, but on Sunday, I have a small group that I take to church. Well, on Sunday after church, we were all at a friend's house, and one of the residents came over, and they all played dominoes. So, it's just like being creative and finding ways to engage them. So that then those other conversations will come later.
And I think you make a good point. If this gets put out as a Medicaid benefit and we start going that direction, we are going to try and figure out what the licensure, what the training requirements are. I think it's something we should all pull together and start thinking about what it can look like. And talking with Brooke and Texas Advocates and other groups that are using this day to day, I think it adds a great benefit. And I think with that, if there's no more questions, I'm going to go ahead and wrap our panel. I would like you all to join me in giving these wonderful panelists a round of applause.